All right, well, we're going to go with part two of our just stimulating and wonderful and exciting talks about hospice regulation. And today we're going to talk a lot about the physician roles, physician responsibility. We're going to talk about the concept of relatedness and talk about audits and things of that sort, which hopefully get your juices flowing for the rest of the day. I know how enthralling these sorts of conversations can be. So hopefully we'll be able to have some time there to explore these topics. One of the things I wanted to do, though, was follow up from last week, because there were a couple of questions that I pulled out of the chat as I was doing kind of my review of the session last week. So for those that were not here last week, we did a part one of hospice regulations and talked a lot about the structure of hospice and the requirements and things of that sort. And there were a couple of questions that came up that I wanted to at least touch on. The first was, the question was, are there any specific strict criteria for how many LCDs need to be met? Like how many of the mentioned LCD must be met minimally? And I just wanted to reaffirm that the LCDs are guidelines, they are not requirements. It's the sort of thing that if you do meet LCD recommendations and those guidelines, that you're probably going to be safe from the regulators, that they'll be less likely to be after you if you meet the LCDs. If you've got someone, for example, with Alzheimer's or CHF or something for which there is an LCD, and they do not meet the LCD criteria, it's always worthwhile to make sure that you are painting a picture and be very, very clear about why you think this patient is eligible if they don't meet the LCDs. But the courts have determined that the LCDs are not binding, they are not required, they are just simply guidelines, not requirements. So, and then two others that had to do with relatedness. One had to do with the role of mental health disorders in hospice relatedness and the impact on hospice eligibility. And if someone, the other question was, if someone's senile degeneration falls and breaks a hip, am I saying that the fall is a related condition and therefore the hospice needs to pay for the expenses related to that? We're going to talk about relatedness specifically and get deeper into that. So I'm going to defer the questions on those two issues. So again, in addition to the objectives last week, we're going to highlight some regulatory issues and discuss the role of the hospice medical director. Again, focusing on the fellows and what your potential roles will be when you finish your programs. I think it's important to know the different roles that you can fill. We'll talk about the medical director position. We're going to talk about admission and certification of terminal illness. We're going to talk about recertification, relatedness of therapies, discharge processes, and audits. So that's really on the docket for today. I mentioned this last week, and it's worthwhile just re-mentioning the conditions of participation is the document and the collection of information that governs what hospices do. So if there's a question about what you need to do, then you can pull the COPs are available online, and that will really help to, if you're looking for some nuanced detail of that. I just wanted to also reinforce that when we talk about this, sometimes we get into quicksand sometimes, and that hospice work is not all rules and regulations. It is a rewarding, challenging specialty in medicine. We work with wonderful teams of committed professionals. We're caring for people at their time of greatest need. The appreciation that you receive, the gratitude can be heartwarming. And I would say generally the lifestyle that we as hospice and palliative physicians lead is a good lifestyle. We tend to be remunerated fairly, and that's an advantageous part of our experience. It uses technical and challenging aspects of science and medicine, pathology, anatomy, physiology, pharmacology, psychology, are all integrated into the work that we do. I can tell you that having a couple of different careers in medicine, starting out first in family medicine, and then integrating part-time palliative medicine into that back in the 80s, and then switching to full-time hospice and palliative medicine in the year 2000. So 23, almost 24 years of full-time now. This has been, I can't imagine a more rewarding career for me personally. And I know that many of you will find that. So the role of the hospice medical director, your primary responsibility is for the provision of services under the hospice benefit. So if you're working with a hospice, patients are admitted to that hospice, you ultimately have the authority over the medical care of that patient. Doesn't mean that you have to see them. Doesn't mean that you are going to become their family doc, their primary care physician. That might happen, but you are responsible for them, which means you need to take time to review the information that comes in, so you've got a good picture of who this patient is. You need to make sure you're communicating with your team, and that's one of the benefits of the team meetings that you have. From a regulatory perspective, there needs to be a team meeting on every patient every 2 weeks. And different hospices do it differently in terms of how they split up the responsibilities, the number of teams, whatever. But you need to have a meeting on that person every 2 weeks. And you, as the physician of record for that patient, overseeing that patient. Because even if they haven't identified attending, you are still responsible for the overall medical care that's delivered from the perspective of Medicare. We have two different certifications that you can achieve. And one is what I would say the standard board certification of a medical subspecialist, which is through the American Board of Medical Specialties. I think most of you will probably be taking a board certification exam upon completion of your fellowship program, and that is the ABMS Board of Medical Specialties that governs that certification process. We also have a secondary certification board. It is a hospice medical director certification board. And this really uniquely, specifically looks at the skills and the talents necessary to serve as a hospice medical director. So you can imagine if you were going through your training and you really love the palliative side of it, and that's where you focus a lot of your energy, time, and attention, and you're looking to get a position when you graduate in palliative medicine, you may not necessarily care as much about the details of being a hospice medical director if you don't ever plan on serving as one. But there are those that really develop a passion for hospice itself. And I will tell you that that this certification board is a nice little addition to the letters after your name and your signature line, because it identifies you as someone who has unique special capabilities in the field of hospice and serving as a hospice medical director. There is a subset of folks who wouldn't and never would be able to qualify for board certification because they didn't sit for they didn't participate in the fellowship program, and they missed the grandfathering period for board certification. And the Hospice Medical Director Certification Board is a certification that is available to them as well. So I would just consider that. I think it's a good thing. I'm certified in both, and they both serve different needs for me at different points in time. So there are different roles that the hospice medical director serves. I'm just going from the top left. As a hospice physician, you are the physician for that particular individual. Now, in many hospices, the patient elects to have the hospice physician serve as the attending of record. So you can serve both roles. You are the hospice physician overseeing the care, but you can also be the attending physician for a patient. In other circumstances, they will retain one of their doctors as the attending of record. You still have the responsibility as the hospice medical director of overseeing the care, and that's the the administrative medical director, the kind of greenish ball down there, is in which you have the overall responsibility for the care. To the left, the inpatient hospice physician. Some hospices have inpatient units, and there are some physicians who really relish that role and focus their attention on that particular area of clinical medicine. Chief Medical Officer is a role that some larger hospices will engage. That tends to be a leadership and governance kind of a role in which you are helping with the leadership team and often the board of directors to chart strategy and an overall approach to care. And so it's a broader administrative role. I would say that some smaller hospices have some of those functions and they just pull their medical director into that role without actually ever calling them the chief medical officer. The one up in the yellowish one, the hospice and palliative physician, it only differs from the hospice physician in that many hospices have a palliative arm. And so not only will you be responsible for overseeing the care of the hospice patients, but you may have responsibility for overseeing the care of palliative patients as well. Now, that might take the role of clinically involved with seeing them and directing their care, or it might be that the palliative program in your particular agency that you join has a team of nurse practitioners or PAs that are doing the clinical work. And again, you are the oversight physician to make sure you're managing the quality and the protocols and things of that sort without actually seeing the patient. And that grayish one on the right, the VP of Medical Services, many hospices have a team of practitioners, physicians and APPs that are involved in the care of the patients. And there again, you may have the responsibility of supervising these particular physicians. So, and just as I mentioned with the CMO role, smaller hospices may have just 1 or 2 or 3 docs or nurse practitioners. And so they may have their hospice medical director serve in that role, supervising those individuals as well. So you can see in a smaller hospice, you may be called the medical director, but you may have responsibilities for every single ball on that particular page. Larger ones might have specific segmented out roles, but those are the different types of roles that you as a physician may be asked to serve. Now, just a regulatory point, it's not a minor issue. It's an important regulatory understanding. A hospice can only have 1 medical director per provider number. So even if they have multiple locations, even if it's a large census, and I've seen, hospices in Florida, for example, that have, they have a census of 1,300 patients. They have multiple sites. They have multiple inpatient units. They have dozens of providers. They can only have 1 medical director. They can have a bunch of hospice physicians, but from the perspective of reporting to the to Medicare, there's 1 person who's listed as medical director. Now, the other physicians in there, you can have lots of them, and they need to have on the organization chart a direct relationship to the medical director. And again, any of the physicians that are on your team can be a designee to serve in the absence of the medical director, so they can continue to do the. And what happens is that in many large organizations, you've got someone who is the designated medical director, but the other hospice physicians, which is a specific term there, hospice physicians, they're doing certifications, they're doing the CTIs, or certification in terminal illnesses, they're doing the addendums and the attestations and things of that sort, under the direction of the medical director. So I've seen hospices that identify their chief medical officer or their VPMA or someone of that sort as the medical director, and they may not actually have on their org chart the medical director title, although it really needs to be there. So that's a technical regulatory issue. You can only have 1 medical director. There are some hospices that have gone away from calling their hospice physicians associate medical directors, because there are some folks at Medicare that were confused by that word associate. And they said, you can only have 1 medical director. We don't care what adjective you use on that. So just so you're aware of that particular designation. What are the duties that you have as a medical director? Well, there's clinical leadership. You guide the team. You help them understand what the protocols are, how to best manage and care for the symptoms that are bothering their their patients. That's your medical expertise there. I get some, excuse me, pushback on this third bullet, leading a hospice interdisciplinary group team, or the IDG. Some people call it the IDT. In most circumstances, you may have someone other than the physician who is actually conducting the meeting, and that's perfectly fine. But you, as the hospice medical director, need to be fully engaged and be seen as a leader on that team because of the medical expertise that you have and the understanding that you have about how to best manage the medical course of these patients. You need to learn how to facilitate a culture of collaboration. One of your jobs is to build relationships with the referring docs, the community specialists, and those that might be in a position to help to support your hospice and send patients your way. If they have a relationship with you as the medical director and as one of the hospice physicians, they're going to be much more likely to say, I feel comfortable sending my patients to that hospice because of the capabilities of the physicians that I've met on that in that organization. You need to identify opportunities to improve care delivery, use resources effectively. As you're looking at the patients and you're talking about them in your team meetings, to determine why is there a lag of 24 hours from patients complaining of a symptom to getting symptom relief? Are we structuring the visit frequency of our patients in a way that optimizes the unique needs of each particular patient? So you can be looking for those opportunities to improve care delivery. And finally, you need to ensure compliance with legal, regulatory, and clinical policies and procedures. You need to work with your administrators on those issues. I find that in most hospices, the hospice physician and the medical director rely upon the administrators to know what the rules are and to tell them as physicians what they need to do. I would just encourage you to take a step further and just understand them yourself so that you know, because at the end of the day, at the bottom of that page that says, I certify this patient to have a prognosis of 6 months or less, it's your signature on that, and you are liable for what happens with that. We're fortunate our docs don't go to jail for the most part. I've seen a few cases where there's abject fraud and abuse. I'm going to talk about those a little bit later. But you want to make sure that your name is associated with compliance. So the patient choice of attending concept in hospice, I think we touched upon this last week. The patient has the responsibility and the right to choose their attending physician. And per the regulations, the attending physician is a doctor of medicine or osteopathy or an NP who is identified by the patient at the time of election of the hospice benefit as having the most significant role in the determination and delivery of his or her medical care. So they get to choose who they want to be their attending physician, who they want to be on deck and be called for any medical issue that comes up. Now, I have seen hospices that will take on a couple of different perspectives. One is that we want to make sure that our community physicians are all engaged, so we're going to allow our patients to choose them, not try to influence a decision, and then we will have in our census of 150, we might have 16 different attending physicians who are all giving different orders on their various patients. It certainly can be done. It's a reasonable way of doing things. It just becomes complicated because, as you can imagine, you've got physicians of different levels of quality and understanding of the hospice process and of the medications we're using, the protocols. And so in those models, I've ended up having to coach the nurses what kind of language and communication to do with the physicians whose patients are suffering because they don't know how to titrate opioids. Another model is for hospices to encourage their patients to consider allowing the hospice physician to serve as the attending. An in-between model is what is sometimes called a first call model. So there may be an attending of record who is your family doc, your internist, your oncologist, your pulmonologist for the patient. But that the patient and the physician agree that the hospice physician will be the one that they actually call if there are medical issues. I will tell you that the vast majority of physicians prefer it that way. They don't want to be called at 2 o'clock in the morning because their patient's, pain is an 8 out of 10. And they don't know that. So the attending physicians are more than happy to relinquish that first call responsibility, and that gives the opportunity of the patients to continue to claim a physician as their attending. The one thing I just need to emphasize about this attending role is that it is the patient's right. You as a hospice cannot arbitrarily assign your medical director or your NP to someone else as their attending. They need to consent to that, and that needs to be their choice. So I'll answer questions we have, but that's an important consideration. Just said that you can't arbitrarily assign an attending. The hospice medical director can be offered as a choice. And if there ever is a change in the attending physician, there is a written request and a form that must be signed and submitted by the patient representative if there is a change in attending. So there's a lot of paperwork that's involved in admitting and managing patients in hospice. It kind of sometimes drives the administrators nuts, but most hospices have become pretty adept at knowing which pieces of paper need to be signed when for what purpose. Nurse practitioners can be serve as attendings. That does vary from state to state, unfortunately, but they are able to see any patient, but may only be able to submit billing for patients for whom they are the attending of record. The AOR stands for attending of record, and that can be assigned. And the physicians can bill all billable visits regardless of attending status. Now, I mentioned all billable visits because not every time a physician visits a hospice patient can you bill. There are what we refer to as administrative visits. And that's where you've got a patient, for example, we're not really sure if they're hospice eligible or not. And so you've talked about it in team, and it would be useful to have the physician lay eyes on this patient. If you're only seeing a patient for the purpose of determining eligibility, that is not a billable visit. You cannot bill that visit. That's considered part of your responsibility as a hospice medical director, and that's considered an administrative task for which you cannot bill. Any questions about this so far? We will continue on. So the admission process. After eligibility is determined, 2 physicians must certify the terminal illness no earlier than 15 days prior to the election of benefit. So the election of benefit is the day that service starts. You can certify them before that. So you may, see that someone's coming down the pike, they're in the hospital, or they're at home, or maybe they have cancer and they've got, they're going to do one last chemo, one last radiation, get one last scan or something of that nature before they actually start. You can certify that patient, but it can't be more than 15 days prior to the election of the benefit. The verbal certification is acceptable, and in most circumstances, we get a verbal certification from the attending and the medical director, but those have to be signed. They can be signed electronically. I just noticed this chat pop up. Physician, as of January 1st, 2019, that physician's assistants can serve as attendings. I would not depend on that. That is a state-specific issue and has not been adopted by many states. The vast majority that does not. You can't do that as a physician assistant. You can be part of the team. You can see patients, but the real advantage of being the attending is that you can bill for the visits. So again, the verbal certification is acceptable. But the billing cannot be initiated until the verbal cert has been signed and the narrative has been completed, and then billing can start. And so it's important to understand that, because a lot of hospices don't understand that. They've got the certifications from the physicians. They start service, they start billing, but the certification is not signed by the physician for a week later. And then they billed for a week of services. That's an administrative denial. It will be denied. You can't appeal. You can appeal that, but you'll be unsuccessful. And if you keep doing that, then they'll consider you perhaps perpetrating some element of fraud. So just make sure that those certifications are done and they're signed. Again, they can be done electronically. Generally, the hospice medical director and community attending physician are involved. If there is no attending, or if it's urgent or emergent, the hospice medical director may act as both, or the hospice medical director can be elected as the attending of record by the patient. And so the medical director can act as both. And I will tell you that in the hospices that I've worked at, that is the model that we worked under. In the vast majority of patients had selected the medical director as the attending as well. This is important stuff here. And I will tell you that this is board stuff too. There's going to be something on the boards about the narratives and about the medical director role. The narrative upon admission and recertification is a brief description of the clinical findings that support a life expectancy of 6 months or less. You need to paint a picture of a 6-month trajectory if the disease runs its normal course. So you're going to want the diagnosis, functional status or decline, nutritional status. If you've got them, lab values. Always you can talk about symptoms, and even if the symptoms are controlled, you can talk about the symptoms that have plagued the patient that are now needing to be actively managed. Falls, behavior changes. Again, those behavior changes may reflect a terminal trajectory. So that's why it's important to mention those sorts of things. Less helpful but valid. Psychosocial issues, if you've got some family dynamics that are impacting that, medication changes, it can be useful as well. Anyone should be able to pick up that narrative and have no doubt in their mind but what this patient is hospice eligible. I've seen too many where I'd pick it up and they say, 94-year-old woman with end-stage Alzheimer's has been getting worse. It's my opinion that she'll die within 6 months if the disease runs its natural course. That tells me nothing. And it tells the regulators nothing either. So your ability, you don't have to be wordy, you just need to be descriptive. You don't want check boxes, no boilerplate language. It needs to be legible for those that are still doing anything handwritten. It needs to be legible because someone's going to look at that and they say, if they can't read it, they're just going to deny it. The date and signature must be in the physician's handwriting and legible or spelled out. Attestation must be present and must follow the narrative and precede the signature and date. I know that sounds kind of picky and trivial, but I have seen denials because they were in the wrong order. You have your attestation, then the narrative, must follow the narrative. You got the narrative, the attestation that you claim, I'm attesting to the fact that this patient is hospice eligible and will die within 6 months if the disease runs its natural course. And that's on the basis of what you've just attested to, okay? Or what you just narrated, I'm mixing words. So narrative, attestation, signature. And if you follow those rules, you can do that electronically. So attestation after the narrative, and then the signature. Okay. So here's a narrative example. Patient's 42-year-old man admitted with a diagnosis of pancreatic cancer. I sometimes, when I was doing these narratives, I will put in the term hospice eligible diagnosis. Just a little extra note that this is a hospice eligible diagnosis. The cancer was diagnosed in October of 2015, found to be metastatic to liver and stomach, PPS is 60%, down from 80% 6 months ago. Anytime you have a decline that you can identify of any metric, you want to do that. He has completed chemotherapy, has demonstrated disease progression, and is no longer a candidate for cancer-directed therapy. He has a poor appetite, continued weight loss, and I believe that his prognosis is less than 6 months if the disease progresses on its expected course after review of the record and admission nursing notes. That's a perfectly acceptable narrative. It tells you exactly what's going on. And no one reading that who has a modicum of understanding of either hospice eligibility or pancreatic cancer would deny that this patient has a prognosis 6 months or less. Now, I will tell you, just as an addendum, I've had people who meet this particular criteria that have been in hospice for 3 years. Now, why are they outliving their prognosis? Don't know. But someone who has that level of disease burden, who has failed treatment with that kind of an illness, by definition and by reasonable medical certainty, which I sometimes use that term as well, would be expected not to survive over the next few months. And I will sometimes put that in a narrative on recertification. Again, this is what the patient has, and on the basis of his diagnosis alone, I would expect that he cannot survive. He has managed to linger longer than expected. However, he is not eating but 25% of his meals. He, spends the majority of his day in bed and sleeps 18 hours a day. So you can use those sorts of language just to validate that the patient is eligible, because he may be extending for reasons we don't understand, but by all the metrics that we have, he is eligible for hospice services. And so you want, and by the way, as we mentioned last week, you have a 90-day followed by a 90-day period of eligibility, and you have an unlimited number of 60-day certification periods after that. So that's your narrative. Following that is the attestation. Based on these findings, my clinical judgment that this patient's prognosis is life expected 6 months or less if the disease runs its normal course, by signing my signature. I attest that I compose the above narrative based on my review of the medical record, or if applicable, my examination of the patient. You sign it, print it, and you date it. So the narratives that you're going to be doing on the recertifications would be similar, but you need to be careful about cutting and pasting. They need to be originally constructed each time you do it. And I've seen challenges in which they clearly are cut and pasted, because I'll see in the last certification period, they lost 12 pounds, and their PPS went from 40 to 30. And I look at 2 months later, the last certification, the patient dropped 12 pounds and the PPS dropped from 40 to 30. So I now have useless information. You're going to be denied, and you're going to have a hard time backing that up if you're just cutting and pasting. So take a moment and put in there what it is that really is going on with the patients. We talked about this last week, certification periods. You have a first, the initial, which is 90 days. The second, subsequent, is 90 days. If you're doing your math, that takes you to 180 days, which is 6 months. So there you go. Third, and all subsequent certification periods are 60 days. Now, you ought to know, you don't need to know the exact numbers, but a few years ago, they changed the payment structure of hospice, recognizing that the highest acuity of staff intervention is at the beginning and at the end. When patients are admitted, there's a really high burden of staff engagement. And when the patient is actively dying, going through their final days, there is as well. So they said, we're going to create this U-shaped model. And one of the things that this was trying to also address is the fact that patients would bring, or hospices that were perhaps working on the margin of ethical integrity would bring patients in before they really were eligible and keep them for months and months and months and months. And they're getting, the same amount of dollars every single day. And you've got these hospices who are trying to work, they'd have patients that would have an average of 14 days, very, very high intensity at the beginning and the end. And so the government said, we're going to change the nature of the payment and not pay as much during those middle periods of time, starting at days 61 and on until the last 7 days of service. So anyway, just so you know.
John, can I just say something about that?
Sure.
So I think you can appreciate this, this organization being nonprofit too. But like in our service, what we've noticed is that a lot of the for-profits, they'll take a patient, anybody that just barely qualifies, they'll utilize that first 6 months and then they just kick them off. And we're taking them, but we're getting the lesser payment, and we're the ones. There is a problem there. Yes, you get more upfront, but if the patient really is barely qualifying, let's say it's a stable patient with dementia 7A and nothing else.
Yeah.
Then, and as soon as they get to like 6 months, they kick them.
Well, so I'm going to just push that a little bit further, because in the hospices that have learned to game the system, they kick them out at day 61. They don't even wait till the second certification, but they're not even waiting till the 90-day. As soon as the payment starts going down, they say, they seem to be stable, so they'll kick them out. And what Matt's referring to, and I'll get to that in just a second, is if someone is discharged from hospice, then they lose the remaining days of that eligibility period. So let's take an example that Matt just said. Someone comes in, not really sure if they're eligible or not, but a hospice thought that they were. They brought them in at day 61. They've discharged them, and they were in fact eligible for hospice services. And so they go to a different hospice who says, "Well, we'll take them on." They come into care not on day 61 of payment, but in the second eligibility period. So they're now under their second eligibility period, and the hospice does not get the advantage of the increased rate of pay for having just admitted someone, because they're not at the beginning of their first eligibility period. They're at the beginning of their second eligibility period. So that's exactly what happens in that particular circumstance. Yeah, Melissa.
Is it always like that though? Like, for instance, if somebody was stable and discharged from hospice after being on for a year or something.
Yes.
And then a year later,
Mhm.
their condition
Deteriorates.
starts to deteriorate, and then they go back and they're hospice eligible again.
They're in their second eligibility
They're
period.
still in a second, okay.
Yeah, or if let's say you've got someone who, these are examples that are real examples. Someone is in the hospital, they've had a stroke, they're declining, they're barely conscious, they're not eating, and family election no feeding tube. And so they're discharged, they go into hospice, and they sort of linger for a few weeks, and now they're starting to eat again, they're waking up a little bit. And so after about, 3-4 months, gosh, I'm not sure that I can claim them as eligible anymore. They're not declining as we expected. So they are discharged for extended prognosis. 3 years later, let's say they got into their second eligibility, they're discharged at maybe day 80 or something like that. So they've already been paid for their first eligibility period. They're into their second. Okay. So they're discharged. They forfeit the rest of their eligibility period for the second period. They're now admitted 3 years later when they develop breast cancer and they're not treated. They're going into hospice. They enter hospice, it could be 3 years later, in their third eligibility period, because they've already been through their first and part of the second eligibility period.
Thank you.
Make sense?
Yeah.
Okay.
You only get one first eligibility.
That's it, okay,
Yeah, you get one first.
okay.
And technically you only get one last also.
So it's more confusing. What if the patient is now on a different hospice that was not informed that they were already on hospice once? Who informs that second hospice?
So who informs that second hospice? Great, because what happens, and especially they move and now they're down in Florida. And the daughter says, yeah, I think they were in hospice for years, but I have no idea who it was. The federal government knows.
Yeah.
And what the new hospice may not know is, well, how long were they in hospice? They can find that out. And they need to find that out, because what's going to happen is if you try to bill for eligibility period number one, then when that bill goes through, the computer system is going to say, we've already paid for an eligibility period number one for this particular beneficiary. For that social security number, they've already been paid. So, but they'll give that information. If you're going to admit someone, the first thing that they do in the billing office is determine, do they have Medicare and what is their eligibility status? And let's say, oh, they've been paid through, 4 eligibility periods. So great, you're going to admit them for the 5th. So this just emphasizes that if a patient discontinues to leave the hospice benefit for any reason during the remaining days of their current cert period are forfeited. And anytime there's a break in service for clinical or regulatory reasons, the patient enters the benefit in the next certification period. So this gets really interesting for hospices that are trying to avoid costs, who admit somebody and that they get sick, they need to go to the hospital to have a feeding tube replaced, or they, maybe they're septic and the family wants hospital care. So they've only been in hospice for 6 days. But the patient revokes, they go to the hospital, and the hospital says, well, no, we can't fix this. They go home, re-sign up with hospice. They're now in the second eligibility period, even though they had 6 days. 2 weeks later, they fall, they call the ambulance, they take them to the ER, family revokes again. Again, 5-6 days, they're back with hospice. Now they're their 3rd hospice admission within a month, but they're in their 3rd eligibility period. Okay. That's how the system works. There are things about the system that don't make a lot of sense, but that's how it works. So after I must say, after the 2nd benefit period, or entering the 3rd benefit period is what that should say. And this has been for a decade now. We've had a new critical component of recertification process for patients entering their 3rd or later certification periods. And it's what we refer to as the face-to-face, or F2F encounter. And this was put in place because of the finding of these long eligibility periods, and they're never ever seen by a doc. And so regulators said, we need to have a doc lay eyes on these individuals, or a nurse practitioner would be fine too. Just to be able to do a fairly comprehensive H&P on these individuals. And so these are the face-to-face evaluations that start prior to the 3rd benefit period. So you've got someone who's 170 days out, looks like they're going to survive another week or so, and you're going to admit them, or you're going to certify for a 3rd period. They need to have a physician or a nurse practitioner. You can go up to 30 days prior to the recertification date to do these. And so this is intended to better enable hospices to comply with eligibility requirements, identify and discharge patients who do not meet the criteria. So those are requirements. Now, there's going to be a narrative. Let me back up. There's going to be a report of that visit. And in most hospices these days, those are done by nurse practitioners. These are non-billable visits because they're administrative only. And so it's cheaper, from a business plan perspective, less expensive to have a nurse practitioner do that and spend an hour at the bedside with the patient than for the physician. The physician must still construct the narrative based on the face-to-face findings of the nurse practitioner. And the nurse practitioner will feed back the information to the team, who will make a determination. Again, it's the physician's determination, is that patient still eligible or not? And so in a really good face-to-face narrative, it's going to be very, very heavily data driven. Here's what we're seeing in the patient. Here's what was, here's what is. And the nurse practitioner in that face-to-face does not predict the prognosis. She just reports data. And the physician makes the determination based on that data, whether the patient is eligible or not.
That's a good point. So the nurse practitioners are not supposed to make a statement on there? Because ours have been, it's my opinion, it's my personal professional opinion that the patient will not make. Sometimes they say that and we're supposed to leave that out.
I would leave that out.
Okay, leave that just to the doctor.
So it's not, I would say that it is not inherently problematic for a clinician to render an opinion. But nurse practitioners cannot certify a patient as terminally ill. Only a physician can do that. So if you're putting that into a nurse practitioner note, it could be interpreted by a regulatory reviewer. We've got a hospice whose nurse practitioner is now prognosticating and certifying terminal illness. And so to avoid that, it doesn't need to be in there. It doesn't need to be in there. Now, the nurse practitioner can tell you, voice to voice, a first person, I just wanted to say, I can't believe he's going to survive another week. You can put that into your narrative to say, based on the above findings, I expect the patient to die within a few days. But you don't want the nurse prognosticating, because that is not the nurse practitioner's role. So as I mentioned, these are regulatory non-billable visits, must be done by the physician or NP. They must be employees of the hospital. They can bill. Now here's one thing, because and I want to be really careful on this point too. The physician can bill a separate visit if there is a billable need. So let's say you go out to do that face-to-face and it turns out the patient's pain is out of control and it's not been well managed. And so you are going to, flip and make this a billable visit because there's a billable need there. You need to make sure that you are independently documenting those differently so that you can bill for the billable parts. But no one picking that up would suggest that, it's really a face-to-face visit and they're just they're fishing for something that can allow them to bill the visit. They see through those things. So you can bill a separate billable visit if a billable service is provided at the time of the face-to-face. You can go to the house once, but you need to document twice. So discharge and revocation, you will discharge someone. Those are different. Revocation, discharge are different. If you judge someone is no longer terminally ill, that shouldn't be last minute. You should, it's an evaluation over a period of time. And the team meeting should discuss some aspect of disease plateau or discharge, and that should occur prior to the notice to the patient of being discharged. So they shouldn't drop that on the ball. You're day 179, we're not sure this patient's hospice eligible. So you send the social worker out to sign discharge paperwork. You need to make sure that there's been some thoughtful consideration of that. You judge them to be terminally ill, and now you're judging them not to be terminal. So you need to have some thoughtful consideration of how you're doing that. And there needs to be some documentation of the conversation. You can discharge if someone moves out of the service area. That's an easy one. They're moving away, and so we can't take care of them anymore. They may move to a facility without a contractual agreement with the hospice. There are some skilled nursing facilities that will only have a small number of hospices which will contract. They don't contract with you. They're going on vacation. You can talk with another hospice in that area who can pinch it if they have some need, but you really cannot discharge for vacations. And you can discharge for cause, and that usually has to do with safety issues, where there are family members that are threatening, or you've got illegal activities going on in the house that place your staff at risk. You may discharge a patient for safety concerns.
Or about cigarette smoking with oxygen tanks.
Cigarette smoking with oxygen tanks is generally not considered a cause for discharge.
Very difficult.
It's very difficult. So now revocation is when the patient can revoke, and they can do it at any time for any reason that they choose. It must be in writing. Verbal revocations are not allowed. It cannot be backdated. Now, the patient may re-elect hospice benefit at any time, but would enter the next certification period as we discussed. So someone who insists on going to the hospital, that's not part of the plan of care. Hospice would not cover that because in our estimation, that's not a necessary treatment. Then the patient can certainly revoke. You cannot discharge them for that purpose because they're still eligible for hospice services, but they can revoke. And the hospice cannot revoke or insist that a patient revoke the hospice benefit. And that's a mistake. I've seen hospices going back, many years that they dial 911 and the hospice nurse meets them in the ER with the discharge paperwork. You can't do that.
So what kind of a conversation is then had? You say, we are not going to cover the cost of this acute medical care, and you're going to be paying out of pocket unless you revoke.
Exactly.
Okay.
Yeah, that's, you can't, we're not covering this because we don't think it's a necessary treatment related to your illness there. And for it to be covered, it has to fall under normal Medicare, which means it would have to revoke. So concept of relatedness. This is an important issue because anything related to the terminal illness is something the hospice is expected to pay. And it determines whether the hospice pays, whether Part D pays for medication or the patient pays. So you want to evaluate medications for deprescribing. Marilyn McPherson did a great lecture on that about 3 weeks ago. If you did not hear that, you want to pull it up on the archives on our YouTube page. It's an excellent deprescribing lecture. You want to evaluate the treatment plan and goals of care. And you want to coordinate with other specialties. Considering dollars, depending upon the hospice, may be something you have to think about. There may be someone who is receiving very, very expensive therapies that are directly related to the terminal illness that the hospice does not have the capacity to support. And that may be something that you would have to then consider in terms of admitting someone. This is really, really busy, so I'm not going to go through it, but what I'm going to just focus on are the key points of relatedness. Again, it determines whether their therapies are going to be covered by the hospice benefit. My rule of thumb is if any condition contributes to the patient's terminality, or as a result of having that condition, they're going to die sooner than they would if they didn't have that condition, that it is related. Okay. Certainly any secondary consequences, someone who has a dementia and now they have developed a wound or aspiration pneumonia, or they're dysphagic, and so poor appetite and weight loss and anything related to those things, that's all related. It's all related to their underlying dementia. The question before about a fall, I've seen folks do that both ways. You might have someone who has Alzheimer's and the result of that is now unstable. They can't walk without assistance, and they try to get out of bed on their own and they fall. That would be related. Okay, it's related to their Alzheimer's. That's just kind of the way it is. I've also seen hospices say, well, no, a fracture is not related, because they could have fallen and fractured their hip being perfectly well. You can nuance that all you want. I can tell you what I do. The therapies are either related but unnecessary, and the ABN is a notice that must be given to the patient that the costs for this particular intervention are not covered by hospice or Part D, and the patient will have to pay. So they're related to the illness, but you determine as a hospice team and as a medical director that it is unnecessary. So someone who is receiving chemotherapy for their terminal diagnosis of cancer, but it really is determined that it's not going to be of benefit to them, you provide this ABN and say, we're not covering this. And Medicare likely would not either. Anything contributing to poor prognosis or caused by any aspect, including treatment with the terminal diagnoses, is considered related. Hospice, and the intention of the government is that hospice cover everything, and they will consider virtually anything the patient has as contributing to their terminality. So you have to make sure that you're explicit in terms of what you are claiming as related. Someone who has hypothyroidism and it's been well managed for 30 years is probably not going to be contributing to their terminal diagnosis, and the hospice would not be expected to to pay for the Synthroid, as an example that is often given. Yeah.
One example that I think is a little sticky is dialysis.
Yep.
It's come up with a few patients, so terminal cancer, not eating, losing weight, but has been on dialysis for 5 years before the cancer diagnosis. And now that is the sticking point on whether or not someone is willing to step forward into what would be appropriate care in hospice for their cancer and the related issues, but wants to continue dialysis.
Yeah. So yeah, dialysis is a unique thing. And in fact, there actually are some proposals in legislation right now that would carve that out and allow for concurrent care, concurrent coverage of dialysis and hospice services, because it can be tricky. In that particular case, to me, that's pretty clear. They're not dying because of the renal failure, and it has no impact on their prognosis. Their terminal cancer is what's caused their death, not related. It becomes stickier if you've got someone who has CHF, and now as a result of the CHF, their kidneys are worsened and their CHF isn't that bad yet, but their CKD is, and so now they're on dialysis, and now they're failing 3 months later, and now they're coming to hospice. Well, clearly, the kidney failure is a direct result of their heart failure, so it is a related condition. And hospices will do different things. I've seen hospices that will say, we as a hospice simply are too small. We cannot afford the cost of dialysis. We'll provide supportive services at no charge, but we're not going to, we can't admit you because we can't pay for the dialysis, not be related. If you've got a definitive date for discontinuing the dialysis, we'll admit you and then can help you transition to that. And I really think there's some hospices that wait till they discontinue dialysis. I think it's appropriate, if we know that their life can be sustained while they're on dialysis, which in fact could extend their prognosis, so they might not die in those 6 months, that when we have a terminal dialysis wean on the horizon, that's a good time to admit and help the family transition to that point. So relatedness is temporal. I mentioned someone who was in the hospital with dementia and sepsis. They're admitted to hospice, but the sepsis resolves, the pneumonia resolves, the hip fracture heals. Now all they have is a dementia. So you need to make sure you're continuing to review these issues, and something that may be related may no longer be related. It may not have been related, but now it is. Or maybe that comorbidity is gone, and so they're no longer hospice eligible. Just a quick word about audits. You will, as a hospice, have claims denied. A lot of times they will ask for additional information. It's called an ADR, and you provide that information. And many times that clears the thing up. Sometimes it doesn't. And if the ADRs don't, then you're going to go through this adjudication process. I have seen a question on every board exam relative to this slide here. So the first step is the redetermination, in which that's done by your local Medicare administrative contractor. The MAC is who pays your bills. They are the intermediary between the government and you. You submit your claim to them and they pay you. So the redetermination is made by them. Well, they denied you initially. I would tell you that I haven't seen a lot of redeterminations that they say, oh, we made a mistake. If you want to challenge that denial, then you go through the reconsideration process. That's done by what's called a QIC, or a qualified independent contractor. And you're going to provide a nice cover letter in exhaustive detail about why this patient was eligible. The reconsideration, you get a little bit more consideration on that than the redetermination, but still those often are still denied. So you can appeal again. That next step is the administrative law judge, the ALJ. And I advise, if you've got a notion that patient was eligible, you should go through the ALJ process. It's not that onerous. It's done these days by telephonic. You're sworn in like you would by any other judge, and you just explain to the judge why this patient was eligible. There is on average about an 85% successful appeal when your case goes from ALJ. So I always recommend that you take it to that level. Every once in a while, you get a judge that doesn't quite understand it. And you can go to the Medicare Appeals Council. If they continue to deny it, then you can actually go to court for that. I don't see a lot of hospices taking it to that level. It really depends on what you're being accused of and what your how strong a case you think you have for an appeal of the denial. So how to learn more about this stuff? NHPCO has some great resources on their website that are available. There are regulatory updates and review courses. I'm sorry, I left a bullet in that I should have removed, the Hospice Physician Compliance Conference. I didn't update that date. I apologize. The Hospice Medical Director Certification Exam, they have great resources in preparation for that. And our Academy has the Hospice Medical Director Manual, which is a really great resource. So NHPCO, AHPM, you can look those up and you'll find some great things. So, and that is just a picture of the manual available for the Academy. So that's what I've got. We're at the bottom of the hour. I know we've got a case coming up, but I'll just take just a moment here to see if anyone has any questions. Hopefully I haven't totally confused everybody. But just hope that you understand that this is important stuff. You need to know this stuff. And you know, you've got great folks within your relative organizations that can help you sort through those if you have any particular specific questions. So anybody have comments that they wanted to throw out there?
Hey, John, I'm just curious, why
Speak up.
why don't PAs do like face-to-face visits? Do you know anything about that? Because we don't have any PAs and I don't see many PAs out there. I don't understand.
Well, the question on PAs is it has to do with what the federal government allows. Okay. And they are just now, I think that there was a comment, someone put a comment in there about PAs serving as hospice attending physicians. And because in general, they have not been allowed to do that. They have not given them the same authority to be able to complete that. I will tell you that is included in many pieces of legislation, and for reasons that I don't fully understand, it usually is lopped out. Okay, so.
John, this is Fred Valentine.
Hey, Fred. Yeah.
You made a good point at the beginning of all of this. At the end of the day, it's about doing the right thing and then documenting well.
I would agree. Yeah, you do the right thing, you document well, and in most cases, you're not going to have any problem. I will tell you that in the review process, that the slide that I showed about the adjudication process, the people that review for the redetermination and then the reconsideration are generally non-clinicians. They are, well, I would tell you in the back rooms, we have our own opinions as to their level of qualification, but I'll restrain myself here. But it's clear that they look for keywords and key phrases, and if they're not there, then they'll deny the claim. But they really have very little understanding about the clinical side of hospitals. So I think that you do the right thing, you document well, and we can defend. Like I said, I've helped hospices at the administrative law judge, the ALJ level, with great success. And you don't need to hire someone to help you with that process. If you get there, you can do it yourself. But if you ever need any help or just some coaching, don't be afraid. I've been doing that work for the last 15 years to help hospices in that process. So,